Interactive, the agency supporting Vera Therapeutics. Before we begin, we would like to take a few moments to get confirmation that you are connected to audio and can see the slides. So to do this, please click the reactions button on the toolbar at the bottom of the screen where you will find an assortment of buttons, including the raise hand, yes and no icon. If you're able to see and hear us, please click the yes icon in the reactions button. If you can do that.
Yes.
All right, perfect. All right. We can go ahead and get started. We kindly ask that you keep your microphone muted when not asking or answering a question to reduce any interference with the program. We also ask you to please refrain from recording or videotaping this presentation. We appreciate your cooperation. Just a reminder that today's discussion is focused on disease state only. Any discussion around therapies or treatments for IgAN or company-specific information is not permitted. Please feel free to ask any questions throughout today's program. We encourage you to use the raise hand feature at the bottom of your screen when prompted. Please feel free to unmute your line to present your question. So at this time, I'd like to introduce Francois Cheristal, Field Medical Director at Vera Therapeutics, to get us started and introduce today's presenter. Francois.
Thank you, Greg. I appreciate it, and welcome all to this program today. So we'll be discussing today the emerging concepts in IgA nephropathy with a focus on B cells and key cytokine drivers of BAFF and APRIL. And our presenter today will be Dr. Arnold Silva. Dr. Arnold Silva is a founding partner and director of clinical research at the Boise Kidney and Hypertension Institute in Idaho. With over 25 years of clinical practice and more than 30 years of scientific research experience, Dr. Silva has pioneered access to nephrology clinical trials in the Pacific Northwest. He earned his bachelor's and master's degrees in biology from California State University, Fresno, followed by a PhD in physiology from the University of Arizona, where he also earned his medical degree. He completed his residency and nephrology fellowship at University of Arizona affiliated hospitals. Dr. Silva is board certified in internal medicine and nephrology with a clinical focus on chronic kidney disease, hypertension, and dialysis care. He has served as medical director of Liberty Dialysis and as director of home dialysis programs, and has held leadership positions at St. Alphonsus Medical Center. His research efforts span anemia management, diabetic nephropathy, Alport syndrome, and polycystic kidney disease. Dr. Silva has been recognized for his excellence in teaching and remains active in mentoring and academic collaboration. So with no further ado, I welcome you all to listen to Dr. Silva. Again, my name is Francois Cheristal. I'm one of the field medical directors here at Vera Therapeutics. Thank you.
Thank you, Francois. I appreciate the very kind introduction, and pleasure to be here this afternoon or evening, depending on where everyone is, to speak with you about IgA nephropathy with a specific focus on B cells and the cytokines BAFF and APRIL. And just a little bit of housekeeping here to let you know that this is a non-CME educational program sponsored by Vera Therapeutics. I'm not a Vera Therapeutics employee. However, I am being compensated for my time today. And also to let you know, the information here is for healthcare professionals for your education, and you ultimately need to use your own clinical judgment when making decisions regarding the care of your patients. So what I'd like to do today as an overview to first talk a bit about IgA nephropathy and unmet needs as far as treatment of this disease state, and then to move into the pathophysiology. We've certainly learned a lot about disease mechanisms in the last few years alone, and want to share some of that with you today. With then some discussion on the two key cytokines, BAFF and APRIL, and talking a bit about B cell activation and how this leads to the disease process. and then to move into what do we do clinically as far as biomarkers in IgA, and then finally to talk about some of the emerging therapeutic strategies and the more recent guidelines that we have for IgA nephropathy. So let's start out with a brief overview, talk about the unmet needs that we're still faced with as clinicians in renal medicine. We've learned a lot about the pathophysiology, and IgA nephropathy is a B-cell mediated disease. It is, in most patients, a chronic disease that is diagnosed through renal biopsy. And it, while considered to be still a rare disease, in complex formation, and the deposition of these complexes in the kidney promote inflammation and kidney damage. This is unfortunately a disease that does not get diagnosed very early. Often our patients are diagnosed somewhere in stage 3 disease, and the consequences are that they've lost anywhere from 40 to 60% of their nephrons by the time that they're diagnosed. IgA nephropathy is also of a global epidemiology. The incidence is approximately what we believe now to be about 2.5 per 100,000 persons. It may be higher than that as we are biopsying more people and doing more biopsies earlier in the course of disease. But this is a disease of young patients, typically in their 30s, 40s, maybe early 50s, more common in men than women in North America and Europe, but the highest prevalence is in Asian countries, Pacific, and lowest in African countries. And the map here just shows that this is indeed a global disease and is present most everywhere in the world. Diagnosis requires a renal biopsy, and typically with light microscopy shown here on the left, we see mesangial expansion and hypercellularity. The immunofluorescence here in the middle part of the slide showing IgA staining in the mesangium, and then finally on the right, electron microscopy showing mesangial and paramesangial immune complex deposits. And we do obtain a MES-C score, and we also use an international IgAN prediction tool when this diagnosis has been made. Well, we've learned a lot in just the last few years, and I think really a major piece of information came from the RADAR cohort from the UK study. And we now know that in the majority of patients that this is not a benign disease. And on the left, you see a number of different curves. These are different age ranges, ranging from pediatric all the way through age 60. And ultimately, the majority of these patients over time will progress to end-stage kidney disease, typically within 15 years of diagnosis. On the right, we have sort of a modified heat map, as I like to call it, is that when you look at annual EGFR decline versus age, many of these patients, especially in the dark orange and red, will progress to end-stage kidney disease. And I always like to hone in the middle, and it's nice that they set up this slide for me this way because here's a patient, if we look where the arrow is pointing, age 35, annual EGFR decline of 2 mil per minute, and that might not seem to be so serious with only that loss per annum, but 80% of patients who are in this range will reach kidney failure within their lifetime. And if you consider that these are young patients, many of them are requiring renal replacement therapy in the form of dialysis or a kidney transplant long before our other patients with chronic kidney disease, especially those with diabetes and cardiovascular disease. We're often not seeing those patients needing renal replacement therapy till much later in life. But this is a disease that comes on early and impacts lives very early on. Well, if we look at our IgA patients and their proteinuria level, and while proteinuria remains a non-specific biomarker, it still is a very useful one in IgA nephropathy. The graph here, which comes from the RADAR study, looks at a family of different proteinuria ranges. And we typically would not even biopsy patients until they got more than a gram of proteinuria. But if you look at the green curve, these are patients with time average proteinuria of 0.44 to less than 0.88. And that roughly corresponds to 0.5 to 1 gram of protein per 24 hours. And if you look at that green curve, is that patients, even in that range, roughly 0.5 to 1 gram per 24 hours, half of them will progress to end-stage disease by 15 years. So this is not a benign disease in the vast majority of our patients, and certainly waiting to biopsy, waiting to make that diagnosis until after the gram of proteinuria, I think we lose a lot of valuable time as far as diagnosis and treatment in this patient population. Well, let's move on and talk a little bit more about the pathophysiology of IgA nephropathy. We know that this is a B-cell mediated disease, and the key cytokines, BAFF and APRIL, they play a central role in IgA nephropathy by stimulating B cells to produce a galactose-deficient IgA and subsequently another B cell line that will produce an autoantibody. And together with that formation, it ultimately results in immune complexes being generated. We believe there could be a number of factors at the top of the slide showing the potential for possibly food antigens, infections, maybe an aberrant mucosal immune response, maybe genetics, maybe alterations in the microbiome. So a lot of things have been proposed and are still being investigated. But what we have when antigens are presented to mucosal tissues, and believe this disease originates in the gut of the patients with IgA, the associated mucosal lymphoid tissues and the antigen presenting cells will then, through T cell independent pathways shown here at the bottom left, and also through T cell dependent pathways, present antigens that ultimately lead to the activation of B cells, which is part of our mucosal immunity. And in IgA nephropathy is when we get an aberrant form of IgA produced. All of us make IgA, IgG, IgM, and so forth. It's all part of our normal immune responses. But in IgA, the regulation in these B cell pathways goes awry, and we ultimately see the production of an aberrant form of IgA, a galactose deficient IgA, and subsequently antibodies that are produced to that. So the second hit of our 4-hit hypothesis ultimately leads to hit 3, which is immune complex formation. Once those circulate and deposit in the mesangium, this leads to inflammation, glomerular injury, and ultimately nephron loss. So we've mentioned some of the potential triggers of this, and again, these are still being discussed and investigated, but ultimately we get an abnormal immune response in the mucosal associated lymphoid tissue, or MALT. And when that activates B cells, which is mediated by BAFF and APRIL, is what starts the cascade of things that happens. And ultimately, BAFF and APRIL, they will have overlapping function to help proliferate, and as well as the maturation of immature B cells, along with subsequently isotype class switching and the formation of mature plasma cells. So lots of things that happen in our B cell mediated immunity, and the consequences, or when we have an abnormal response, we get the production of an abnormal IgA. And like we've been discussing, the formation of the galactose deficient IgA, gal deficient IgA, along with antibodies to that, ultimately forms immune complexes. And those circulating complexes, when they wind up in the kidney, is what leads to inflammation and subsequent nephron loss. And what we see clinically when this happens is progressive loss of kidney function, along with proteinuria, and in most patients, hematuria as well. Well, let's talk a bit more about the cytokines BAFF and APRIL and how they drive B cell activation. So BAFF and APRIL, they are members of the tumor necrosis factor family of signaling proteins, and they will act via a shared B cell receptor, TACI. And TACI is a common receptor for both BAFF and APRIL on plasma cells. And the activation of this receptor pathway ultimately leads to B cell proliferation, as well as B cell survival and maturation, along with the class switching to produce IgA producing B cells. And on the right, the cartoon shows BAFF and APRIL and some of their functions. BAFF plays a role in B cell survival as well as plasma cell survival, as does APRIL. And then via the shared TACI receptor, you have T cell independent responses along with isotype switching. So a lot of cellular processes that have a certain amount of overlap between the cytokines as well as the shared receptors. And all of this is happening upstream long before there is the impact on the kidney. And so what we've believed now for some time is knowing what is happening with these cytokines and the activation and maturation of B cells along with isotype class switching, these cytokines represent potential therapeutic targets. So ultimately, on the left, where we have BAFF and APRIL, if we were to block these cytokines, that we could certainly slow down this activation and proliferation of B cells and ultimately lead to reduction in autoantibodies, less immune complexes, and consequently less deposition in the kidney. Well, when we look at these cytokines and their levels in patients with IgA on the left, we see that BAFF levels are significantly elevated in IgA patients. They're here on the left versus healthy subjects and controls. We also see APRIL levels in IgA nephropathy being significantly elevated in our patients with IgA nephropathy. And what does this translate to, or at least what does this correlate to clinically? Well, serum BAFF levels here on the left are shown to correlate with proteinuria. So the more BAFF, the more proteinuria. And on the right, when you look at different tertiles of APRIL, the patients with the highest levels of APRIL have the highest risk of progression to end-stage kidney disease. So it's interesting how all of this fits clinically, and I think it makes a lot of sense now that we understand this disease process and how this translates to the clinical parameters we measure and ultimately the clinical outcomes in these patients. Here's some more data with BAFF and APRIL. On the left, we can look at serum IgA level versus BAFF. So the higher the BAFF level, the higher the IgA. In the middle, we can see higher BAFF levels are also correlated to higher levels of deposition of IgA in the mesangium. And then on the right, looking at APRIL levels, this is the GAL-deficient IgA versus APRIL. So higher APRIL, higher GAL-deficient IgA. So what do we do clinically as far as biomarkers in IgA nephropathy? In the clinical setting, the things that we typically will look at, of course, are hematuria, proteinuria, as well as renal function measured by GFR. And in some cases, people will measure levels of galactose-deficient IgA, although I would say that most clinics will be using hematuria, proteinuria, and eGFR measurements at this time. And for anyone who is a molecular enthusiast and wants to know really what happens to the IgA when there is a galactose deficiency, there's an alteration in glycosylation in the hinge region. So maybe that's a handy fact for Trivial Pursuit. I don't know, but anyway, it's where the defect is. And when we look at the amount of galactose-deficient IgA compared to total IgA, that's increased in our patients with IgA nephropathy. And when we recognize gal-deficient IgA, when the immune system recognition of that, and that's recognized by both IgA and IgG antibodies, that ultimately forms the nephritogenic immune complexes. And thus the circulating complexes winding up in the mesangium is what leads to renal injury. If we look at serum levels of galactose-deficient IgA in patients with IgA disease and healthy controls, they are significantly higher. And on the right, when you look at proteinuria, there is a correlation between the severity of proteinuria and serum galactose-deficient IgA, so the abnormal IgA, or immune complex levels. So, and I think that makes sense too. So the more abnormal IgA or the more immune complexes you see, the more renal injury, and thus the more proteinuria that's observed clinically. Well, the other thing that we look at too is hematuria. And while microscopic hematuria is very common in IgA, it is not specific for IgA. Nevertheless, it's detected in 70 to 80% of patients with the disease. And approximately half of the patients with glomerular disease who have microscopic hematuria will get a diagnosis of IgA nephropathy after their kidney biopsy. So as we said at the outset, most common form of glomerular disease, and even though hematuria is not specific for IgA, half of those patients with microscopic hematuria get diagnosed with IgA nephropathy. The other thing to point out is that hematuria can be macroscopic or microscopic. And the interesting thing is that the patients with macroscopic hematuria seem to do better clinically over the long haul. And we're not quite sure why that is, but it's possible that because of the almost the dramatic impact that macroscopic hematuria has on the patient, that they may seek medical care sooner than those with microscopic hematuria who are maybe not even aware of anything going on as far as their health is concerned. In addition to proteinuria, we believe persistent hematuria is also important to look at. If you look at the graph on the left, renal survival free of end-stage disease, those with persistent hematuria there in the red graph, they do not do as well. Overall, their renal survival is significantly less over time than those without hematuria. And on the right, renal survival free of a 50% reduction, even though we're looking at a different parameter here, 50% loss. If you have hematuria, you don't do as well as if your hematuria has resolved. So another important biomarker for us to look at clinically. Now, if we get back to the radar data again, our family of curves here, and this is the more recent database from 2023. We also had earlier data from the Toronto GN registry that also pointed to higher amounts of proteinuria, higher levels of proteinuria that correlated well with decline in renal function. And so again, even patients that are in that less than 1 gram per day there is a significant percentage of them that will progress to end-stage disease within 15 years. Well, where should we try to target our therapies then, and what sort of clinical biomarkers can be helpful to us? On the left, these show EGFR trajectories in adults with IgA nephropathy and vasculitis from the CURE-GN study. And the group in green, this looks at their EGFR over time. So this is going out past 6 years after enrollment. The patients in green had a UPCR mean of 0.2 grams with a range of 0.1 to 0.4. That's encouraging when you see patients with a very low level of proteinuria and seeing how stable their GFR is. The middle group here in yellow, they didn't do as well. They had a mean proteinuria of 0.9. And to put that into context, 0.9 is a level that not too long ago we wouldn't have even biopsied a patient. But when you look at these patients, they have a progressive loss of function, losing about 2.5 mil per minute per year with significant loss over just a few years. And then ultimately those that are approaching more nephrotic range proteinuria of 2.8 grams with a range of 1.8 to 4.1, they are losing EGFR much more rapidly. And how that translates to, when you look at the curves on the right, those in both the mid-range there in yellow and the more aggressive disease with much higher proteinuria, those groups do not do well over time. Even those in the 0.9 mean proteinuria, the curve, the yellow curve, shows that in about 6 to 7 years from the time of enrollment, about 25% have progressed to end-stage disease. This is an interesting family of curves, but what it tries to put together is that if you can achieve, regardless of the treatment, and you see a number of treatments here on the right, fish oil, steroids, immunosuppressive therapies, RAS blocking therapies, if you can achieve a 30% reduction in proteinuria, that you'll have a significant and positive impact as far as their EGFR slopes are concerned. So it's important to get proteinuria down. We know it's a risk factor, but we also know it's a modifiable risk factor. And the sooner we diagnose and treat, the better these patients are going to do. So potentially then, for us, where we stand now by newer therapies that are in development, reduction of the production of galactose-deficient IgA, and consequently reduction in immune complexes that should reduce glomerular injury, and you should see clinically resolution of hematuria, reduction in proteinuria, and stabilization of GFR. So where do we stand now as far as our therapeutic goals, and what are the guidelines currently telling us? Well, KDIGO had not said much about IgA nephropathy in about a decade, but we had an update in 2021, and then just 4 years later, 2025, we get another update. And that's really because of all of the emerging science and the new treatments that have been in clinical trials. And the clinical practice guidelines have been updated regarding diagnosis, prognosis, treatment, as well as special situations. And So we had an update in 2021, another in 2025, and I would suspect within another year, given all that is happening in this disease state, that we'll probably see another update from KDIGO. So what KDIGO wants us to consider and to acknowledge is an immediate need for therapy to prevent nephron loss. And we know that these patients are already presenting with stage 3 disease. And so to avoid progression to end-stage disease, we really need to focus on therapy that's going to preserve remaining nephrons. But at the same time, we also need to look at managing the consequences of injured kidneys that already have lost approximately half of their nephrons at the time of diagnosis. So things to consider, on the one hand, looking at the drivers of the disease, it's B-cell mediated disease, so addressing those factors, but also looking at nephroprotective strategies to help protect the remaining nephrons. So in KDIGO 2025, they want us to focus on eGFR stabilization as well as proteinuria reduction. And we know that patients that are in that 0.5 to 1 gram per day of proteinuria, that's too high. So at the very least, we want to get these patients below 0.5 and ideally below 0.3. And I showed you some data from the CURE-GN study that patients who are in that range, less than 0.3, they actually can do very well for a long period of time. So looking at our treatment algorithm, it's gotten a lot more complex in just the last few years. And so once the diagnosis has been made, if you look on the left and on the right, this is not a typical algorithm. They're wanting us to think about everything all at once. And in the middle, you really should consider in your patients all of these things simultaneously. So on the left, thinking about the drivers of this disease by stopping the synthesis of pathogenic IgA, which ultimately should help stop immune complex formation. And then on the right, to also take on nephroprotective strategies at the same time to reduce hyperfiltration, proteinuria, and also control blood pressure. And then there's the orange box up there, because our patients with chronic kidney disease have increased cardiovascular risk. So strategies to help reduce their risk for cardiovascular events needs to also be considered simultaneously with protective strategies for the kidney. So to put this all together, lots of new but exciting information. We know that IgA nephropathy is, for the most part, a chronic autoimmune or at least immune-mediated disease. It's probably going to require lifelong management in the majority of patients. This is a disease of young patients, and half of them will probably progress to end-stage disease within 20 years. So we need to diagnose earlier. We need to be addressing both the drivers of the disease as well as nephroprotective strategies for the remaining nephrons. And clinically, we need to be looking at hematuria, proteinuria, eGFR, and possibly galactose-deficient IgA. And, you know, as we move forward, the consideration of therapies that are currently in clinical trials and bound to be emerging here in the next few months to year or so should help stabilize GFR and decrease at least for many patients, their risk of progressing to end-stage kidney disease. And so that's um, that's what I have, and happy to answer any questions you might have.
Oh, thank you so much, Dr. Silva. That's a nice review. Thank you. You know, the way you speak, you remind me of Dick Glassick, which is a
Oh,
big compliment to you.
why, thank you so much. I've been a fan of Dick Glassick for a long time, for really all my career. So, well, that's a very nice compliment. So, thank you.
You're welcome. I was just curious, and I mean, I can understand if you're not sure of the answer, but with this really busy playing field that we have now for IgAN, and with sibeprenlimab recently FDA approved, and I mean, do we know? I mean, do we really need to block both APRO and BAFF? Can we just block APRO? I mean, just want to sort of, I guess, do the least amount of damage, if you will, onto the immune system that we can get away with. I don't know if you know the answer, but I again, if we don't need to block both, that would be nice.
Yeah, that's a great question, and it's one that I've been getting and see circulating in a lot of these talks. Um, at this point in time, we don't really know, and I don't think in the very near future, unless we begin to do trials where we compare. Uh, Blocking just April versus BAFF and April until we would actually see that, um, we probably can't answer the question all that well. I will say that as more of these therapies um, emerge and get approved, I suspect we're going to have a year from now a number of choices as far as therapies. We're probably going to learn more by gathering post-marketing data to help answer that question. But it is certainly one that people ask because we know April is a major player. We also know that if we just block BAFF, it really doesn't do much. But if we block April, we've seen results there. If we block BAFF in April, and so that's where the studies have gone and the development of therapies. But um, one versus two, I think it's going to take us a while before we can answer what might be the better strategy.
I think it might have been presented in the last ERA Congress, but I was hoping that maybe if you blocked both, you would have more of you might be able to have free time, time away from drug, like a rest, and be able to have sustained, proteinuria decrease, Gd-IgA decrease. But I believe the data for atacicept showed that, time off of the drug, all the biomarkers started to go back to before, in the wrong direction. So unfortunately, that didn't quite pan out because that would have been a nice niche, for being able to if you were to block both and to be able to have drug-free period. But I don't believe the data proved that way. But Francois, you can correct me if I'm remembering this wrong.
No, that's correct. The thing too is that with that particular discontinuation data, if you recall, it wasn't necessarily to assess efficacy alone. It was really to, and mainly I would say to look at safety in a sense. So it's unfortunate at the time I can say that we didn't collect any proteinuria data to see how that was tracking once we had that discontinuation period. But I think in the phase three, we're going to look at that to see how that's tracking as we are blocking the cytokines once upon stopping the medication. But I mean, you raise a good point. We would hope to, I mean, I've been hearing in the field from several different nephrologists. They believe perhaps if we have a time period of 3 to 5 years, maybe that might look different versus the 96 weeks period that we had, and then we stopped the medication. So there's a lot of questions that still need to be answered, and we're not really sure at the moment, to Dr. Silva's point as well.
And
Yeah,
now,
I
go
think
ahead.
we've learned a lot, but we've got a lot more to go. So
Right.
And now the hot topic is looking at IgA protease enzymes to actually target the IgA complexes.
yes.
So that's the new hot um, talk now in IgAN. And that would be really cool because if you can target the pathogenic complex, then you could leave the rest of the immune system alone, and that would make a nice, safer, more, a safer long-term treatment option for our patients.
Yeah.
Yeah, I think there's a lot of interest in that, and we shall see where we go with that. I think we've got a lot more that we need to do.
Yeah, but I have a question for you, Dr. Lau. So, uh, to your first question, that blocking one may have less impact on the safety versus blocking both. If I'm understanding your question well, do you think the current safety profile that we see from both type of modalities make a difference from a safety perspective?
Uh, I'm sorry, can you say the question again? I don't
So,
understand.
so blocking one cytokine, APRIL, versus blocking both BAFF and APRIL.
Mhm.
To your first question earlier, mentioned that perhaps if blocking one may have less uh, impact as safety is concerned versus both. I was curious to know what's your interpretation currently with the safety data that we have from both sets of studies so far.
Well, I don't know that it has shown so far in what's published data, but
Hmm.
we'll have to wait till real world, with the use of it in more patients, but in terms of what's published,
Hmm.
no, you cannot tell the difference.
Okay.
Yeah, I know there's theoretical, at least theoretical concerns that people raise, but there no hard data really to
Right.
show that this safety profiles are different between April versus April plus BAFF.
Right. Yeah, it's just a lot to learn with this space for sure. And we have the NT-CD38s also that are in development too.
What is that?
The NT-CD38s,
Oh,
um,
yes, of
yeah,
course. Yes, yes. Felzartamab,
felzartamab and
the one that
mezagitamab.
begins with an M.
Yeah,
Yes,
mezagitamab as well.
mezagitamab
So
as well. Yeah.
yeah,
Hmm.
it's exciting times, and some people are even raising questions. Well, maybe we could think about one of the B cell modulating therapies, BAFF/APRIL, plus um, a CD8, CD38. So there's a lot of interesting questions people are raising, and so we'll see where it all goes.
Yeah.
Well, thank you so much again, and I will see you guys another time. I gotta get going, so thank
Okay,
you.
thanks.
Thank
Thanks
you,
for
Dr.
joining us.
Lam.
Most appreciated.
Have a good
Uh,
evening.
Okay.
Dr.
Thanks, you too.
Lau, real quick, if I should say before we end the program, please direct your attention one more time to the chat box to complete our brief attendee evaluation form. Your feedback is very important to us. Please click the link provided in the chat box or scan the QR code on the screen to open a new tab in the web browser. Once you've opened the evaluation form, feel free to leave the session. Again, thank you, Dr. Silva, Dr. Lau. Thank you, Francois, as well. And I wish you all a wonderful day. Thank you.
Yeah. Thank you
Thank
for
you so
joining.
much, everybody.
Good night.
Okay.
Thank you.
Good night. Bye-bye.